innovative and a good intern. Thank you. All right, great. Thanks. Okay. Well, thanks for having me tonight. I'm going to talk about so I basically have maybe a pessimistic perspective on the future of medicine and then an optimistic perspective, and this is my optimistic talk. I like to quote Arne Nies, the Norwegian philosopher, who said, "I'm a pessimist for the 21st century and an optimist about the 22nd century." I think it may be the same in medicine. We currently have a disease care system, and I think we're in for a number of changes, maybe not for the better immediately, but eventually we'll get to where I hope we're headed, and that's what my talk is about tonight. Health-oriented medicine instead of disease-oriented medicine. And I believe an important approach to that is an ecological approach. I use the term future primitive ecology here to refer to an approach of essentially approximating or simulating the evolutionary ecology of humankind, and I'll get more into that in a second, why that's the approach I think is critical. So I'm going to move quickly. We don't have much time tonight to cover a big concept, so I apologize for going quickly. But the quickest way I could summarize health-oriented medicine was with this slide, which is a gross oversimplification. But essentially, I want to use the approach of positive psychology. If you've heard of this subdiscipline of psychology, it's essentially a group of psychologists who want to look 180 degrees in the opposite direction of conventional psychology, which is really towards health instead of towards disease. The founders of this positive psychology, you could call it health-oriented psychology, simply realized that people don't want to be depressed because they want to be happy. It's kind of self-evident, but it's an important flip in perspective, because then they said, let's study happiness, if that's the goal, and try to enhance that. Instead of avoid mental illness and avoid depression, we want to enhance and enable happiness. Health-oriented medicine does the same thing. Basically recognizes that people don't want disease simply because they want to be healthy and feel healthy. And so the goal is to study health and try to enhance it instead of just prevent disease. So this is a really busy slide. I'm not going to go through it all, but I simply wanted to say that obviously to progress in health-oriented medicine, we need to define health. It has to be a positive concept, a positive entity, an operational paradigm in itself. And I've been working to do that. This is some of my work. What I mostly want to point out here is that I refer to health as a dynamic entity or a process that involves two interdependent domains of efficacy and resilience. As you see in this column, and the lines didn't show up very well, but as you go across in these different areas, you can see there's analogs to efficacy and resilience in Chinese medicine, Ayurvedic medicine. Complex system sciences and in Western sciences use autopoiesis. Homeostasis is actually a medical term as well, but there's a lot of analogs, a lot of synonyms in other disciplines, including process ecology down here at different scales. They all refer to the same entities of efficacy, or the same concepts of efficacy and resilience, essentially. So I'm not going to spend much time on that. I want to move ahead to ecology. And to get to ecology, I want to start with where we're at right now. As you know, genes and the Human Genome Project and genomics have been a major emphasis in biomedicine for decades now, and the Human Genome Project was the big hope of the late 20th century, and was going to provide all of these answers, and of course it hasn't. And the reason it hasn't is, according to scientists today, the reason it hasn't is because, well, the genes turn on and off, and there's 30,000, 35,000 genes. They argue about that. But essentially, we have an infinite number of possible combinations. We have to understand how they turn on and off and why they turn on and off, and what these combinations are going to produce. So now, the rave is epigenetics. And you hear about epigenetics, and how that's radically altering our understanding of genetics and genomics. So those epigenetics lead to protein transcription. So really what we're trying to get at with epigenetics is the proteome, or the combination of all proteins in the body. And the study of those dynamics is proteomics. But why should we stop there? All the proteins in the body produce byproducts, and they process materials, and they have actions themselves, and those taken in total are called the metabolome. And we can refer to metabolomics. That might be another decade or two down the road, we'll be interested in metabolomics. But of course, the metabolome is just a part of the whole organism. All the emergent properties of a metabolome come together to create what we are, a full organism, an autonomous organism with emergent properties like the mind and the psyche. Some have referred to this as the phenome, a combination of the genome and the phenotype. And I expect, there's just a fringe group right now kind of looking in that area. I think that'll become a major interest in maybe 3 or 4 decades. I don't know. Science moves slowly. But an organism doesn't exist in isolation. Of course, it exists in an environment, in an ecosystem, and the built environment, the anthropogenic environment for us. So some scientists are interested in something called the exposome, which is what they use to refer to the total environmental exposures over a lifespan, is the exposome. So exposomics is already being discussed as something we should investigate in trying to understand the influence of environment on disease. However, our immediate ecosystem is part of the larger system, part of the Earth, the biosphere, and we could really maybe gain some insight into disease from looking at geophysiology and biogeochemistry. So, as I said, up here at the most reductionist side of this is epigenetics, where we're really at right now. What I'm interested in is this interface between organism and environment, and that's the definition of ecology, how an organism interacts with its environment. And the reason I think that's important is, maybe the most obvious reason is, number one, that's where we make decisions as individuals. I don't consciously, anyway, make decisions about what genes are expressed or what my proteins do. I do make decisions about how I move about the environment and what I consume from it, what I exchange with the environment. Those are decisions I feel like I have control over. So this is really the scale, the dynamic interface where we can exert an influence on ourselves and the environment. And so the second reason is because that's just exactly where the organism and the environment are created, is at the level of ecology. And there's a great amount of evidence for this from a number of different disciplines, but essentially what controls epigenetics is ecology, how we interact with the environment. The environment is the information that tells our genes how to respond and what proteins to produce. And by interacting with the environment, as it's building and designing our bodies continuously as an organism, we're changing the environment. So we create the environment, and then it influences the body. And it's a interdependent dynamic. So ecology controls everything you see, from the most reductionist to the most holistic, or the microcosmic to the macrocosmic scale on this slide. So just a couple quick points to sort of summarize some of that concept. An organism and its environment are interdependent and interdeterminate. They've co-evolved, and they essentially operate as an indivisible developmental system. If you've read much about developmental system theory, this is very much something I'm interested in, and trying to use that to understand health and influence health. If you think about it, you don't just pass on genes. Reproduction doesn't pass on just genes. It passes on a number of cellular substances that are important for those genes to operate. And you pass on an environment that every generation works to influence and change, sometimes for the better and sometimes for the worse. So health and disease are the moment-to-moment product of organism and environment interaction. That's ecology. And I like to refer to organism-environment concordance, the match between these two domains that are basically in agreement. They've co-evolved and they're in step, they're in sync with one another. That concordance is what determines health, whereas discordance would determine disease. So I think instead of talking about our genetic potential for any attribute, or genetic potential for a disease, or genetic potential to be really healthy, we should be talking about our environmental potential. What potential do we have to be healthy or happy or perform well given our current environment? So just to look at this through another species, it's a little more intuitive and obvious, I think. When you think of a cockatoo in the wild, and it makes sense why they could be quite healthy in the wild, whereas we think of a cockatoo in captivity, and it's very common, if anybody's a bird owner or visits zoos frequently, it's very common to see manifestations of disease in captivity, and that's because it's much more difficult to provide a concordant environment, and it's very difficult to simulate or approximate that environment. So this is true of humankind as well. We have a natural habitat environment we co-evolved with. Here's a group of Australian Aborigines from 1930 that are in a concordant environment, still living as hunter-gatherers. I always like to point out this man in the middle. I would guess he's probably in his 50s or maybe 60s. And he looks like he spends all day in the gym and has an incredible diet. He works really hard at his health. Well, he doesn't. He's just in a concordant environment, and this is the product of that environment. Whereas nowadays, Australian Aborigines are in a discordant environment like the rest of us, and their health is apparently affected. So I like to refer to human ecology as in 5 divisions. Really, it's all connected, and these are arbitrary divisions. You can divide it in any way you'd like, but these are how I divide it. And as you see, it spans, these are divisions which span scales from the microbiome, the organisms that are symbiotic with our bodies, through the body all the way up to the biosphere. Because of time today, I just want to focus on a couple items from one category. The EMR is electromagnetic radiation. Our interactions with that category, that division, include the whole electromagnetic spectrum that we're all familiar with, but it actually includes, the way I divide it, includes much more, including electromagnetic interactions between other organisms and other people with the surface of the Earth, and chronobiology are the rhythms of all of these energetic, the dynamics of these energies and how these rhythms are superimposed. So has anybody in this room or everybody in this room heard of grounding and earthing? It's really taken off in the last probably 2 or 3 years. Really has become a big subject. And I think it's actually extremely valid. And it's something that the evolutionary paradigm that I'm using, the future primitive ecology, predicts. That there's some value to having more regular, non-insulated contact with the Earth. That's the way we've co-evolved. So it would make sense that there's a health value to that. Well, recent data, and they produce more and more evidence every time I look in the journals, it validates that is true. There's a number of surface electrons, free electrons on the surface of the Earth that act as antioxidants when they enter the body. They have a natural flux. When sun hits the Earth's surface, it creates a flux of these free electrons. That flux seems to entrain circadian rhythms, help anchor our daily rhythms. And so there's a number of benefits, and now technology is allowing us to simulate this. Since we live in a discordant environment, fairly insulated environment, we have to try and figure out ways to engineer the environment where we're at today and try and approximate this future primitive ecology. And so you have sheets that have silver threads through them. You have shoes that have copper conducting points on them. data still needs to be generated to see how effective some of these are, but the point is it's a valid hypothesis, and we're using technology to create a more healthy future by approximating this primitive ecology. Another one that's not as validated yet as grounding, but I think is to come through a very similar process, is a recognition that sunlight exposure to our skin, to our retinas, is critically important. And that makes sense. We've co-evolved in contact with sunlight. We all now know over the last decade or so the critical importance of vitamin D. Conventional medicine has come around to recognize how important that is. But it's not the end of the story. It's not the only thing sunlight on the skin produces. Sunlight on the skin and the retina control and modulate our neurotransmitters, melatonin production, and this is the vitamin D at the dark, major cancer preventive molecule, antioxidant, melanin production, which gives our skin pigment, our circadian entrainment, and then cholesterol sulfate and vitamin D3 sulfate, as you see the sulfate's important, are part of a new sort of hypothesis I'm calling the sulfate hypothesis, that basically states that the sulfate in cholesterol sulfate, and it's got to be in these forms, not any sulfate, but cholesterol sulfate and vitamin D3 sulfate are very critical for healthy physiology, and these are only produced, this is the hypothesis still to be validated, these may only be significantly produced by sunlight on the skin. But it looks like, looking at physiology and kind of synthesizing evidence, that they may help prevent, or deficiencies of these compounds may contribute to this cluster of interrelated diseases. So the thinking is humans are photosynthetic in a way, not quite like plants, but we synthesize important compounds from a photoelectric type effect. So the question is, if we don't all live at the beach in a tropical environment, what do we do about insulating ourselves in the cold environment? And so my thought is we do this for plants. We give them a greenhouse. They photosynthesize in a warmer environment that traps warm air. And so can we do that, something similar for humans? Greenhouse jackets, transparent, translucent jackets. It's not quite this simple. These are all I could find as far as examples. These are translucent jackets. But it's got to obviously be the correct wavelengths hitting the skin that provide the most efficient synthesis of vitamin D3 sulfate and cholesterol sulfate. So the question is, what about the harmful effects of UV? This is why we wear sunscreen. This is why we're supposed to avoid the avoid the sun. I think that's a bit of a misconception by science. The actual cause of the UV damage may be a step away. It may not be the direct exposure to UV, but a deficiency in epithelial pigments and antioxidant pigments in the skin. And these are a list of common antioxidants that are well known to help prevent the UV damaging effects of sunlight on the lens of the eye, on the retina of the eye, and on the skin. And if you think about it, this is not unique to humans. Pink flamingos are born white. They acquire their pinkness through eating the Haematococcus algae and dinoflagellates. And that it provides astaxanthin, this top antioxidant there, excuse me, which protects them from the UV light that they live their entire lives under. And humans really do the same thing. Evolutionarily speaking, we acquire all of these compounds you see there through our diet. Astaxanthin is what makes salmon pink. We can get that from eating salmon. Anthocyanins and other compounds are involved in a lot of fruits and vegetables that have colors. We can get more of those. So essentially, I think we're deficient in these protective pigments. And the best approach to UV radiation is to get exposed to it well in the presence of adequate antioxidant pigments. And then we get the benefit and we minimize the harm. And that's all I have for you today. If you want to explore this further, I put a lot of thoughts up on my website. And you can connect with me through there if you'd like to.
All right, well,
All right.
let's give him a big round of applause.
Thank you. You need this?
Let's give him a big round of
Thank
applause.
you. Good evening. Thanks for showing up tonight. My name is Bill Blanchett. I appreciate getting invited here. I'm an internist. I've been practicing in Boulder since 1983. And although I was introduced as a number of things, basically my identity is as an internal medicine physician. I'm interested in colon cancer because it impacts my patients. The problem with colon cancer is that it's not only a treatable cancer, it's a preventable cancer. But most people never take the steps necessary to prevent it. And so what I'm going to talk about tonight is something called CT colonography or virtual colonoscopy, which is an alternative to traditional tube colonoscopy. And now that we have an easier way of doing this, then no one has an excuse to die from colon cancer. So what's the current data? Well, comparing the two technologies, I use the allegory of the bear. The obvious joke is, why do you never fish in bear country alone? And the answer is so you don't have to outrun the bear. So I'm not going to promote virtual colonoscopy as being a perfect technology, but I'm going to say it is as good a screening technology, if not a better screening technology, than conventional colonoscopy, and I'll show you the data to support that. So basically, in 2005, it was determined that no colon cancer screening was perfect for detecting either cancer or adenomas. However, the expert panel, Joint Guidelines, American Cancer Society, Multi-Center Task Force, American College of Radiologists say that CT colonography is equivalent to conventional colonoscopy for detecting polyps and screening for colon cancer. So let's talk about colon cancer for a second. There are about 150,000 new cases of colon cancer every year in this country. And about 52,000 people die from colon cancer every year. And once again, the real tragedy is this is truly a preventable cancer. Colon cancer is the second leading cause of cancer death in this country, responsible for about 10% of cancer deaths. 1 in 16 Americans will develop colon cancer, so a couple people in this room will likely develop colon cancer unscreened. 1 in 40 Americans will die from colon cancer. After diagnosis, the 5-year survival is about 64%. If colon cancer is found early, the 5-year survival is over 90%. And furthermore, colon cancer can be detected in precancerous states, where we're not even looking at survival. Unfortunately, only 39% of cancers are diagnosed at early enough stages. And so, once again, a very preventable disease. The U.S. Preventive Task Force. The U.S. Preventive Task Force is a group of people who doesn't recommend anything for anybody under any circumstances. And they think that everyone over 50 should be screened for colorectal cancer. So looking around the room, there's no one here that qualifies, but you can tell your parents about this technology later. So we used to use sigmoidoscopies to screen for colon cancer, but sigmoidoscopies only looks at the lower part of the colon, misses over half of the colon cancers. And the U.S. Preventive Task Force doesn't like sigmoidoscopy screening because they say when you visualize the colon, you see teeny tiny polyps that leads to other procedures taking out the polyps that are unnecessary. And so tiny polyps are very unlikely to become colon cancers, and with sigmoidoscopy screening, it led to too many polypectomies that had no impact on clinical outcomes. Why do they say that? Well, the data supporting that is that when you look at polyps smaller than 1 centimeter in size, fewer than 1% of them will become cancer in the lifetime of the individual. And so we take out all these little teeny tiny polyps, we're really not doing that much cancer prevention. But while we're doing a colonoscopy, we're in there, we're saying, well, here's a polyp, let's take it as long as we're here. The problem with that, though, is there are sometimes complications of doing that. If you look at polyps greater than 1 centimeter in size, 10% of them will become cancer within the next decade. So if you have a larger polyp, that one should come out to prevent it from becoming cancer. Optical colonoscopy is the kind of colonoscopy that we all know about. That's what, when we say it's time to get your colonoscopy, that's what we're talking about. And for the last decade, it's been considered to be the standard for colon cancer screening. And I have nothing against optical colonoscopy. Anyone who wants to get optical colonoscopy, please get it. But for these 60 to 70% of people who never get around to getting optical colonoscopy, the CT colonography is a good alternative. The optical colonoscopy can visualize and remove polyps from the entire colon. Unfortunately, it's expensive. It requires sedation. It takes a day out of your life. 60% of people takes 2 days out of their lives. And there is some risk of bleeding and perforation from optical colonoscopy. The U.S. Preventive Task Force says it's unclear whether the increased accuracy of colonoscopy compared to alternative methods of screening offsets the procedure's additional costs, complications, and inconvenience. So let's talk about CT colonography for a second. CT colonography, the U.S. Preventive Task Force in 2002 reviewed this and said, is a non-invasive procedure for producing images of the colon and lumen. Studies have not yet examined clinical outcomes. Well, since 2002, studies have examined outcomes, and we'll talk about those. Interestingly, as of when this was published in 2005, this was a synopsis of all the studies looking at conventional colonoscopy compared to virtual colonoscopy. And we see that pretty much most of them show that with 10 millimeter polyps, the clinically important ones, there's a very high detection rate with CT colonography, except for this one study where they missed almost half the polyps by CT colonography. Interestingly, this study was sponsored by a gastroenterologist. It was done in inexperienced centers using poor technology, two-dimensional technology, without stool tagging. Suffice to say, it was a group of people who were not experienced in doing it, who were doing a bad technology, and they got bad results. It'd be like you had internists doing hip replacements. You'd get bad results. But all the other studies found anywhere from 75 to 100% of the polyps by virtual. Every gastroenterologist you talk to will quote this study as a reason not to do a virtual colonoscopy. But there are variables in detecting polyps by conventional colonoscopy and by virtual colonoscopy. And I'm going to just breeze through this because this is beyond the detail that you'd want. But there are a number of things that will distinguish who's doing a good virtual colonoscopy and who's not doing a good virtual colonoscopy. And with the conventional colonoscopy, there's also things that are variable. The speed of the examination is one of the variables that's really quite interesting. They look at miss rates with tandem colonoscopies. And historically, the miss rate for tandem colonoscopy has been considered to be nothing. If you do a colonoscopy, you find all the polyps. End of story. Then they did a study comparing virtual colonoscopy with conventional colonoscopy, and it turns out conventional colonoscopy was missing a lot of polyps. So instead of saying it's 98% accurate, maybe it's 86 or 83% accurate, depending on which study you're looked at. But the most important one is variation in adenoma detection rates amongst different gastroenterologists. This is a great study. A private practice of 12 gastroenterologists looked at what percentage of patients do they find polyps in and how fast do they withdraw the tube. It turns out the gastroenterologists doing the fastest tube withdrawal were missing anywhere from 50 to 70% of the polyps found by the gastroenterologists who were doing slow tube withdrawals. And so the point here, simply said, is that conventional colonoscopy is not as perfect a technology as we once thought it was. And so between these 12 experienced gastroenterologists, mean detection rates of polyps greater than 10 millimeters in size was 6.6% for gastroenterologists who took their time and 2% for those who didn't. So a wide variability in polyp detection rates, threefold difference. Total polyp detection rates, there was a tenfold difference. So here's a study that's somewhat daunting. This is a study out of Canada. Now we have to remember no one in Canada does anything as well as we do it in this country. But what they did is they took a group of patients in the database who had normal colonoscopies and said, what's the likelihood of being diagnosed with colon cancer after your normal colonoscopy compared to the unscreened population? And they found out at 6 months, this group had 69% of the risk of the unscreened population of being diagnosed with colon cancer. By 5 years, they had 55% of the risk of the unscreened population of being diagnosed for colon cancer. And by 10 years, which is when we recommend your next colonoscopy, it was down to 28% of the risk of the unscreened population. So it took me a while to figure out why these numbers were even possible. And I realized two things. Number one, I was saying in Canada, they don't do good things as well as we do. But secondly, these patients came in with more symptoms. They're more likely to have blood in their stool. They were a skewed population. But once again, the point is, it's not perfect. Colon cancer misses stuff. In this country, a study just came out showing that colonoscopy reduces cancer death by 51%. That's great. Why does it not reduce cancer death by 100%? I mean, 51% is good, but 100% would have been better. And so here's the first study that was really meaningful with virtual colonoscopy. It was published in New England Journal of Medicine way back in '03. They took 1,233 asymptomatic patients at Bethesda Naval Hospital who volunteered to have a virtual colonoscopy and a conventional colonoscopy the same day. I assume they got out of marching duty to do this or something, because I would have trouble volunteering for both of those procedures. This is what a polyp looks like on a virtual colonoscopy in a three-dimensional mode. This is the two-dimensional mode on a virtual colonoscopy. This is what a polyp looks like with optical colonoscopy. And what they found, the virtual colonoscopy found 93% of the 10 millimeter polyps, almost 94% of the 8 millimeter and larger polyps. The smaller the polyps, the lower the detection rate. When you look at the optical colonoscopy, they actually found a smaller percentage of the 10 millimeter polyps. The virtual found a higher percentage of the larger polyps. As the polyps got smaller relative to virtual, the conventional found a higher percentage of the polyps. But the thing that's kind of striking is conventional colonoscopy found one colon cancer, but they missed a cancer that was found on the virtual. The virtual found 2 colon cancers. The conventional only found 1 until they had the roadmap from the virtual to see it hidden behind the splenic flexure. So the virtual found 2 colon cancers, but the virtual also found 5 cancers outside the colon. 1 kidney cancer, 1 ovarian cancer, 2 lung cancers, and 1 lymphoma. All of them were found stage 1, potentially curable. And so when this study came up, I made the observation, turn these numbers around, you never hear the word virtual colonoscopy again. The conventional colonoscopy had found 7 cancers and the virtual had found 1. This technology would be punted and we'd be off looking for something else to do. The fact that the conventional found 1 cancer and the virtual found 7, the experts said, well, maybe this is something we could someday think of if it ever gets better. Here's another study published, well, actually it's the same study, I apologize. They also found stuff outside the colon, kidney stones, aortic aneurysms, incarcerated hernias. So the extracolonic stuff above and beyond colon cancer screening was pretty substantial in this particular study. Now, you hear a lot of concern about you're finding all these things outside the colon, it's going to cost a lot of money to follow up on them. They actually did a study looking at that. It costs $20 per person who gets a virtual colonoscopy to follow up on the extracolonic findings and determine who has cancer outside the colons. In symptomatic patients over the age 70, they had a group of 400 consecutive patients over 70 who presented with symptoms. Weight loss, blood in the stools, changed bowel habits, anemia. 49 of these folks had cancers. 29 were inside the colon, 23 were outside the colon. And so with virtual colonoscopy, they could detect the pathology inside or outside the colon with one procedure. That one procedure would cost less than conventional colonoscopy costs, and it actually is priced less than traditional CT scan of the abdomen would cost. So with one procedure that costs less than either of the other procedures that would be needed, they found what was going on in these patients. And in addition to that, 116 subjects had extracolonic lesions, clinically significant, things you would not see on a conventional colonoscopy. JAMA in 2006 pointed out that screening in the very elderly is actually dangerous, and you have to question whether what you're going to find is going to justify doing the procedures, the risk of the procedures. And so once again, the virtual colonoscopy is much safer. It's much less invasive. It's an easier procedure to tolerate. And then here's another study. It's published in 2007. And in this study, they had a large number of patients. Let's see. There were 6,600 patients who were sequentially assigned to either virtual colonoscopy or a conventional colonoscopy. So it wasn't a truly randomized study, but it's reasonably randomized because they're just sequentially assigned. You have your number 1, your conventional, your number 2, your virtual, your number 3, your conventional. And this is what they found. Advanced adenomas or carcinomas were found equally in both groups, 3.2% versus 3.4% of the patients. The optical colonoscopy group had many more polyps removed. So they removed almost 2,000 more polyps. But the same number of clinically important polyps were removed. And so what happened is you're dealing with 2,000 less polypectomies, 2,000 less opportunities for bleeding or perforation, 2,000 less specimens that need to be sent to pathologists to say this is nothing to be concerned about, for the same number of clinically important polyps. When you look at the comparisons, even though it was not randomized, it was pretty close to the same groups. The age was about the same. People got optical colonoscopy on average a year older. Family history, the people with optical colonoscopy had about 30% more family history. So you might expect a little bit of a trend towards the optical colonoscopy finding more pathology. And here's what they found. When it comes to the 10 millimeter polyps, they found the same number of polyps. The 6 to 9 millimeter polyps, the optical found a slightly larger number. However, when it came to number of carcinomas, the conventional colonoscopy found 4 colon cancers. The virtual colonoscopy found 14 colon cancers. That actually reached a statistical significance with a p-value less than 0.02. And so the question once again arises, are we missing significant polyps on conventional colonoscopy that we're actually finding on virtual colonoscopy? One of the things that's also described in the literature, but not by studies, just by experts' opinions, is that virtual colonoscopy cannot find flat polyps, and flat polyps are a little bit more pernicious than projecting polyps. In this study, the virtual colonoscopy found 12 flat polyps, the conventional only found 2. So yes, flat polyps may be hard to find, but they're no harder to find by virtual than by conventional colonoscopy. So once again, this is a 3-dimensional virtual colonoscopy looking down the colon. It's kind of fun to look at these. It's like doing a colonoscopy on a cartoon character because you're just tubing down the colon. Polyps pop out, diverticuli pop out. Here's the polyp on a 2-dimensional view, and here's the polyp as it's coming out on a colonoscopy. The chief investigator of this study is a guy by the name of Perry Picard, and he did a virtual colonoscopy on his father and found an early colon cancer on his father, who he couldn't have talked into doing the conventional, but when the virtual became available, he did the virtual and found colon cancer and happened to save his pop's life there. So in this particular study, 3,300 patients in each group, optical colonoscopy found 4 cancers, but it perforated 4 colons. 4 required abdominal surgery to repair. The virtual colonoscopy found 22 cancers in the same number of patients, 14 colon cancers and 8 cancers outside the colon, and there were no complications in any of the patients, including the 8% who had to be crossed over to doing a conventional colonoscopy to take out the polyp that was found on virtual colonoscopy. The conclusion of the study is that, based on these results, primary CT colonography or virtual colonoscopy should be the screening test, and optical colonoscopy should be reserved for people who have clinically important polyps. Cost effectiveness of optical colonoscopy is $9,000 per life year gained. Virtual colonoscopy with a 6 millimeter threshold for follow-up costs half as much per life year gained. If you put no threshold for follow-up, it costs 2/3 of optical colonoscopy for every life year gained. And so in summary, virtual colonoscopy finds a higher percentage of large polyps and colon cancers. It's safer, requires no sedation, lower incidence of complications, perforation, and bleeding, more cost effective, and because you don't need a sedation, you can go back to work immediately after the virtual colonoscopy. I had my virtual colonoscopy at 9 o'clock in the morning and saw my first patient at 10 o'clock the same morning. You can't exactly do that with optical colonoscopy. And that's just some technical stuff, and that's my daughter on the sand. So the procedure consists of a prep that's, I'm not going to make it out to be a good thing. The prep is a prep. But the colonoscopy prep, you have to drink this gallon of lovely salty lemonade. With the virtual, the prep is you drink a bottle of magnesium citrate, chase it with 4 Docalax pills, and then you drink the clear beverage of your choice. So you don't have to drink the gallon of salty lemonade. You get kind of cleared out. As part of the prep, we give you some barium, which tags any remaining stool in the colon. So if the bowel is not completely swept clean, we can distinguish is this a polyp or is this a piece of stool. And in the procedure, you come in, we put a small catheter into the rectum. So instead of inserting a tube the full length of the colon, you get a catheter the size of a small straw in the rectum, and we insufflate the colon with carbon dioxide. The reason we use carbon dioxide is it's readily absorbed into your body, so So after we're done with the procedure, we let out the gas that can come out, and whatever can't come out gets absorbed into the bloodstream, blown off through the lungs, so you don't play your tuba any longer than you have to after the procedure is done. And then we do a low radiation, high resolution CAT scan through the abdomen and pelvis. Because we're looking at the interface between soft tissue and air, we don't need a lot of KUVs of radiation to make that distinction. So actually the virtual colonoscopy, even though we're looking at the abdomen and pelvis both lying on your back and lying on your stomach, it uses less than half the X-ray energy as doing a diagnostic abdominal pelvis CT scan. We finish the procedure, you get up, you drive yourself home, so you don't need to have a driver drive you in. There's no waiting for the anesthesia to get gone. There's no IV, there's no IV fluids. And we're not using a tube that we have washed since the last person. We're using a tube that was manufactured new. And we get through with it, we throw it away. So you don't have that concern of, did you guys wash this tube well enough since the last guy with hepatitis C that you did a colonoscopy on? And so that's my story on virtual colonoscopy. How does an internist get involved in doing virtual colonoscopy? I actually got involved with doing EBT heart scans. And with the EBT heart scans, it's a revolutionary technology that makes heart disease a thing of the past. But virtual colonoscopies actually can make a profit. Heart scans don't. So I'm hoping to do enough virtual colonoscopies that I can continue doing heart scans, because that's where my passion is here. Questions?
Insurance coverage?
Insurance, as of last year, almost all commercial insurance covers it. As of this year, Medicare is the only one that doesn't in Congress right now with party co-sponsors to get Medicare. We take the images, send them by high-speed internet to Duncan Barlow. So when someone gets a virtual colonoscopy at our facility, the same guy who did the president's virtual colonoscopy gets to do their colonoscopy. So when the first study came out, they said, well, this is good results. In a specialized center of expertise, can this be reproduced in Podunk, Colorado? My answer is, we're not reproducing in Podunk, Colorado. We're sending it back to Bethesda and having the world authorities look at the pictures. And Duncan Barlow has done colonographies on 40 of the congressmen who are sponsoring this bill that Medicare is going to cover the procedure. So, yes, ma'am.
You said it's cheaper than the conventional abdominal CT. Why is that?
Because when it first came out, it was not covered by insurance, so it had to be priced at a price point that people would be willing to pay for it. Whereas CTs, because they're covered by insurance, were priced at absurd price points. And so the most hospitals will charge $1,000 for each part of the body they CT. If you're doing abdominal and pelvic CT, that's $2,000. The virtual colonoscopy is $775 for the whole thing, including interpretation. The conventional colonoscopy is anywhere from $1,500 to $3,000, depending on who does it. Yes, sir.
I've read a few articles recently that talked about the relationship between diet and colon cancer. You know, maybe you can shed some light on if somebody eats a plant-based diet versus somebody who does a lot of eating dairy. Is there a significant difference that you've seen?
Yeah, well, not that I've seen, but the literature kind of supports that. The first description was by Dr. Burkitt, who was a missionary, basically, a medical missionary in Africa, who noticed that the African diet had a lot of twigs and berries in it, and not as much meat as our diets did. And the incidence of colon cancer in Africa was very, very low at the time. And so more studies have been done with that, and there is, yes, protective effects of a lot of things with respect to colon cancer. Of interest, aspirin, 81 milligrams of aspirin reduces colon cancer by 35%. There are a lot of foods that have substances that are fairly similar in effects to aspirin. Fiber appears to be a beneficial thing as far as reducing risk for colon cancer. Things that increase colon cancer: cigarettes, alcohol, high-fatty diets. And so if you have a high-fatty diet, make up for it with lots and lots of fruits and vegetables.
And then, what about oxidative stress and the role of colon cancer? Can you shed any light on how that affects things?
Actually, I'm all about oxidative stress and the role in heart disease. Colon cancer, inflammation is a risk factor for any kind of cancer. And so I don't have any better answer than that with oxidative stress and colon cancer, except that inflammation tends to be a promoter of cancer in almost all organs. Chronic pancreatitis is a risk for pancreatic cancer. Chronic esophagitis is a risk for esophageal cancer. Ulcerative colitis is a risk for colon cancer. And so those are the big things, but bring it down to smaller things, I'm sure there is a factor with oxidative stress.
What's the futuristic things that you're doing with the heart scans?
Well, actually, the other person who's going to be here was Steve Parcells, who's going to be talking about heart disease. And if Steve is not here, I could take a couple minutes and talk about heart disease and heart
Let's
scans.
go ahead and do that. So Steve, apparently possibly in the room or something.
Heart disease is the biggest killer, isn't it?
By far, heart disease kills more people than all cancers combined, plus accidents and influenza. So yes.
Is it preventable?
It is, heart attacks are preventable. I don't know that heart disease is preventable, but heart attacks are certainly preventable. And so basically my passion is the prevention of heart disease. And a couple of misunderstandings about heart disease is, my father had heart disease, but I'm so much healthier than my father, I don't have to worry. Turns out genetics is the strongest predictor of heart disease risk of any predictors that we have. And my cholesterol is normal, I don't have to worry. There was a study they did looking at 103,000 heart attacks. 103,000 patients presented to the hospital with heart attacks. 50% of them had cholesterol LDLs less than 100. 77 had LDL cholesterols less than 130. We consider LDL cholesterol less than 130 not requiring any prevention. We consider an LDL cholesterol less than 100 as an ideal target for treatment. Half the people had LDLs less than 100, 3/4 had LDLs less than 130. 103,000 people presented with heart attacks. They looked at another 48,000 people presenting to these 500 reporting hospitals who did not have coronary disease, who were admitted for non-cardiac diagnoses. Their cholesterol, the people admitted with non-cardiac diagnosis, had slightly worse cholesterol numbers than the people admitted with heart attacks. So we kind of look at our cholesterols and say we're in trouble, we're not in trouble. It has very little to do. Measuring your baseline cholesterol has very little to do with predicting your risk for a heart attack. Now, if you have risk, making that cholesterol better reduces that risk, and that's important. But using a cholesterol measure to measure your risk just doesn't work. And so coronary calcium is what I was introduced to. I was drugged kicking and screaming to a talk on coronary calcium about 9 years ago. And I listened to this person who, I used to call coronary scans or calcium scans, calcium scams with an M. But a friend told me I had to go see this talk. I listened to him and he quoted the literature and I was like, this guy's telling the truth, I've been missing out on something. So I went back and looked at the literature, and not only was he telling the truth, he wasn't telling the whole truth. This was just an amazing technology that I'd been blinded to because I wasn't doing my own research, I was listening to my cardiology colleagues. So I've done more research and I've kind of become somewhat of an expert on coronary calcium and coronary prevention. My position is we now have effective medical therapy which can prevent a majority of coronary events, providing we're able to determine who's at risk and in whom our intervention is not working. And so coronary calcium imaging is what I do, and it's using an electron beam tomography. Electron beam tomography is different than a 64-slice scanner. And the electron beam tomography can take an image in 5/100ths of a second. The fastest 64-slice scanner takes an image in 1/3 of a second. So in 5/100ths of a second, you can catch the heart without any motion. But at 5/100ths of a second, we don't have enough radiation, enough energy going through to get a quality image. So we've stretched it out to 1/10 of a second. In 1/10 of a second, we still take a picture without any motion of the heart because we time it when the heart's not moving. And we get good quality pictures to measure the calcium in the coronary vessels. It turns out the amount of calcium in the coronary vessels measures baseline risk much better than Framingham risk factors. The MESA heart study was just published a couple of years ago, multi-ethnic study on atherosclerosis, found that coronary calcium was 10 times more predictive of coronary events than all risk factors combined. It motivates people to make needed changes. When a person goes to their doctor and the doctor says you need to be taking a medicine to lower your statin, writes a prescription, gives them a prescription, 50% of those people will not be taking that prescription within 12 months. That's the best statistics we have. It's usually more like 75% will not be taking the prescription. But when you can tell a person you actually have disease, the compliance with therapy is dramatically better, not only with respect to taking the medication, but with respect to weight loss, with respect to improvement in diet, with respect to improvement in glucose control. And the final thing is coronary calcium measures residual risk. Residual risk is this concept that we think you're at risk for heart disease, we have you on treatment, and you still have a heart attack. How did that happen? You have residual risk. We weren't treating you well enough to prevent the heart attack. And so coronary calcium, the EBT coronary calcium can measure residual risk. So let's talk about this study. This is a study of 5,600 asymptomatic patients. And they were looked at various risk factors to try to see what risk factors predicted the risk the best. They followed this person for, the average was age 36 to 70, average is 51. They followed them for 9 years. No, it's plus or minus years, I'm sorry. They followed them for 37 months. Let me say that again. Average age 51 years, followed for 37 months. They looked at age. Age was surprisingly not much of a risk factor in this group, but it was a select population. Looked at smoking. Smoking increased the risk by about 40%. Elevated total cholesterol in this study did not increase risk at all. In fact, there was a trend towards elevated total cholesterol being associated with less risk for heart attacks. Diabetes doubled the risk. Hypertension increased the risk by 1/3. The presence of any calcium increased the risk tenfold. Here's another study, heart events in apparently healthy people. If you look at novel risk factors, highly sensitive C-reactive protein plus total cholesterol divided by HDL cholesterol had a 5-fold difference from lowest quartile to the highest quartile. The HSCRP by itself was fairly weak. Total cholesterol divided by HDL cholesterol, all in the single digits. Calcium score above the 75th percentile had 15 times the risk of a coronary event. So once again, a dramatic stratification of risk above and beyond conventional risk factors. Here's a small prospective study where they followed 623 patients for 32 months. The calcium score was 0. The annual risk for heart attack was 1/10%. As the calcium score went up, 1 to 100, this annual risk was 2%, greater than 100, 4%, greater than 400, almost 5% annual risk. 5% annual risk for heart attack is pretty high risk. Compared to conventional risk factors gave you very non-robust increase as you increase from first, second, third, fourth quartile of risk factors. Coronary calcium between the first and second quartile had no change because 50% of us have calcium scores of 0. 50% of us have a very, very low risk for heart disease. By the time you got to the third quartile, the risk increased by 6-fold. By the time you got to the fourth quartile in this particular study, the risk increased 21-fold. Once again, a powerful predictive risk, dramatically better than conventional risk factors. St. Francis Heart Study, 4,600 patients followed for 4.5 years, determined the coronary calcium was not only a risk factor, but is an independent and incremental risk factor compared to all conventional risk factors. And they found basically the same results. The MESA Heart Study, 6,700 men and women, 4 different ethnic groups. A number of risk factors were followed, including HSCRP, carotid IMT, all sorts of advanced cholesterol markers. The conclusion is the coronary calcium score is a strong predictor of incident coronary heart disease and provides predictive information beyond that provided by standard risk factors, and in fact, 10 times beyond that. HSCRP, interestingly, anyone who's into lipid markers has heard about HSCRP, highly sensitive C-reactive protein. The reason you've heard so much about highly sensitive C-reactive protein is that Harvard owns the patent and gets a click anytime anyone in the country orders one. In the MESA Heart Study, the baseline HSCRP was the same in the people who had heart attacks as those who didn't. In fact, there was a statistically insignificant trend. The baseline HSCRP was slightly better in the subset of people who ultimately had heart attacks in the study. And so a lot of people think that HSCRP is the new novel risk factor to find out if you have heart attack risk, and it's not. Body mass index. That's, obesity is a horrible thing. It kills everybody. The body mass index and hip circumference was the same in the group with heart disease and without heart, or with heart attacks and without heart attacks. So my conclusion, and I'm not just saying this because I'm fat. My conclusion is that obesity is the whipping boy that conventional medicine uses to explain its inadequacies in predicting heart disease. Since everyone's fat, Anyone we didn't think was going to have a heart attack who has a heart attack, we can blame it on them being fat. Mesa Heart Study would say that's probably not a valid conclusion. The calcium score greater than 300 was associated with a 16-fold increased risk of heart attack compared to a calcium score of 0. Too much detail. They did a study, EBT versus angiography, a number of years ago. This is kind of interesting. And showed that your baseline calcium score was more predictive than an invasive catheter angiogram in predicting heart attack risk. They had 288 patients who had a calcium score and a coronary angiogram the same sitting. 7 years later, they followed up, and they found that indeed their coronary calcium score was more predictive than their coronary angiography results. Coronary calcium score over 100 was the strongest predictor of heart attack risk. And in this relatively small study, conventional risk factors had no value in stratifying risk. So blood pressure, smoking, diabetes provided no clinical value in stratifying risk. So how can EBT be more predictive than coronary angiogram? This is how. It's called Glagov's theory of coronary remodeling. As you start putting plaque in a vessel, the plaque doesn't obstruct the vessel, it remodels the vessel. So here's a normal lumen and a normal vessel. Here's a normal lumen with a vessel that has plaque pushing the wall of the vessel outward. Here's a normal lumen with a fair amount of plaque. Finally, only when you get really severe disease does the lumen start getting smaller. This was published back in 1987, so this is not late-breaking news. This is old news. Intravascular ultrasound is a new technology. The intravascular ultrasound, you put a probe in the vessel and bounce sound waves off the walls of the vessel. So this is the intravascular ultrasound. This is the guide wire that it goes over. This is the lumen of the vessel, and this big crescent here is atherosclerosis. This is a coronary angiogram. This coronary angiogram is basically normal. This is where the first picture is looking at. Normal looking vessel by angiogram, nice round lumen with a huge amount of plaque. Here's C, normal looking vessel, nice lumen with this crescent of plaque. You also see these little bright spots. This is calcium in the vessel. So here's a person who would have a normal angiogram, who would have an abnormal calcium score, and would have definite risk for a coronary event. Because coronary events are not caused by cholesterol obstructing the vessel, coronary events are caused by plaque rupturing the vessel filling with clot. Angiograms don't measure plaque rupture, they just look at the lumen of the vessel. Coronary calcium looks at the plaque in the wall of the vessel, and the more calcium in the plaque, the more unstable the plaque is. So the criticism is that calcium doesn't identify soft plaque. That's an accurate criticism. But they just did a study, or the confirmed registry looked at patients who have soft plaque, who have no calcium in that plaque, and their annual risk for heart attack was 0.3%. It was a very, very low risk, despite the fact they had plaque. If they had plaque and they had calcium in the plaque, their risk for an event was like 20 times higher. It's a dramatic difference. So the calcium determines who has plaque. It also determines the physiology of that plaque to a certain extent. So I consider coronary calcium as measured by EBT imaging as a technology that accurately predicts risk for future heart attacks, dramatically better than risk factors, dramatically better than stress testing. One of the great myths is that I just had my executive physical, I had a stress test, I'm doing fine. Got nothing to worry about. Tim Russert was told that 5 weeks before he died from a heart attack. Who's the Beatle who just died? David Jones had a stress test last summer. And he was bragging that he said, I did so well, my doctor said I can do anything I want. And I was dead from a heart attack. Bill Clinton had a stress test a couple years before he almost died and had a multiple vessel bypass. Bill Clinton's story is kind of sad. As the president, he did have a CART scan. He has a high calcium score. The cardiologists who were taking care of Bill Clinton, as the president of the United States, didn't know what to do with a high calcium score. They did a stress test. He passed the stress test. They said, you're fine. 2 years later, he's almost dead. So one of the problems that we'll run into is going against doctors' ignorance about the value of a stress test. A guy by the name of Lukenau in some Scandinavian country that contains people named Lukenau did a study on stress tests, had 1,700 men, asymptomatic, did stress tests, followed them for 10 years. 86% of the heart attacks occurred in the men who passed the stress test. And we still do stress tests. I'm going to skip through this. Talked about compliance with medications. Here's a study. They found that of patients in the top quartile, after 3 years, 91% were still compliant with statin medications. Now we can argue for a while whether statin medication is the best way to treat heart disease. But if you can get people to comply with what they should be doing, that helps. And normally we get no more than 50% compliance. In this study, those people who need it the most had a 91% compliance. Dietary modification improved compliance. Increased cardiovascular exercise probably improved compliance. Quitting smoking, not so much. And then finally, measuring serial coronary calcium scores, this residual risk that we're talking about. So we have a few studies. The first study was an angiographic progression study. This was done in Japan. They had 43 subjects who had a quantitative angiogram and a coronary calcium score the same day. And then 2 years later, they did the same thing. 10 of these subjects had progression of their coronary disease by angiography. 33 subjects were stable. What's kind of scary is that of the subjects with progression, 50% had hypertension. Those subjects who were stable, 64% hypertension. Those who progressed, 50% were on statin therapy. Of those who were stable, only 30% were on statin therapy. Not exactly an endorsement for statin therapy. Those who progressed, total cholesterol was 198. Those who were stable, total cholesterol was 202. So all the normal things we would follow as clinicians to say you're winning the battle, you're losing the battle, had no correlation with who progressed and who was stable by quantitative angiography. Across the board, the annual increase in calcium scores was 38%. Among those who had progression, the annual increase was 117%. Now, you have to realize that to get progression in serial angiographies over as short a period of time as 2 years, you have aggressive disease. To get a 117% increase in your calcium score, you have aggressive disease. That said, I talked to someone this afternoon who had a 270% increase in their calcium score, and we determined we needed to be doing more about his disease. The mean annualized increase in calcium score in the 33 stable patients was 16%. And so, as it turns out, a 15% annualized increase is stable plaque. If your plaque burden, if your calcium burden goes up by 15%, it means you're more densely calcifying existing plaque. If your calcium burden goes up by more than 15%, it means you're adding plaque to the pie. So that's my target for treatment, is keeping the calcium from going up by 15%. Here is another one of those IVUS studies. And this study, Steve Nissen, the head of cardiology at Cleveland Clinic, is showing that with high dose of Lipitor, some people will get regression of their plaque. And so this is the IVUS before and this is the IVUS after. You can see the lumen is bigger. But if you look at the IVUS before, calcium, 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 calcium. If you look at the IVUS after, less calcium, less calcium, less calcium, less calcium. And so you didn't have to stick a needle in this guy's groin and run a catheter to his heart, put a wire in the vessel and bounce sound waves. You could have him lie on a table, hold their breath for 30 seconds, and get the same answer for something like 1/100th of the cost. So in the St. Francis Heart study, this is not published, but talking to the investigators, the strongest predictor of coronary events was not the initial scan, but the change over time in the calcium score. Sadly, these investigators have trouble getting this published because it's going against the grain of conventional cardiology. Matt Budoff at UCLA did a very small study. 225 subjects followed for barely a year. The relative risk of heart attack based on progression greater than 10% versus less than 10% was 13-fold. In the MESA Heart study, calcium score greater than 14% was associated with about a 10-fold difference in coronary vascular events. There was another study that I don't have listed here out of UCLA that found a 3-fold difference in all-cause mortality based on progression. I'll show you this last study and then I'll quit. This is my favorite study. A guy by the name of Paulo Raggi in Tulane had 495 patients. All had coronary disease based on EBT calcium score. All of them were asymptomatic. All of them were placed on Lipitor and followed for 6 years. During the time, 41 heart attacks. The group that had heart attacks had an average LDL of 118. The group without heart attacks had an average LDL of 122. Now, this study was centered in Louisiana and Tennessee, so the LDLs down there are higher than they are here. Point being, LDL did not distinguish who was going to have a heart attack and who wasn't. 20% of these patients had 0 increase in the calcium score, and there were no heart attacks in that 20% of the population. Progression of heart attacks less progression of calcium less than 15% per year, 3% of those subjects had heart attacks. Progression of calcium greater than 15% per year, 34% of the subjects had heart attacks. 17-fold difference in heart attack risk across the board between progression versus stability. If I put you on a statin and you take it and you get your cholesterol down to goal, I've reduced the risk for heart attack by 21%. 20% in women, 22% in men. If I treat you to the point that your plaque is stable, according to this study, I've reduced the risk 17-fold. This is what it looks like, stable plaque, progression of plaque. My last and favorite slide in the world. This dark line is patients whose calcium scores were over 1,000. If the calcium score was over 1,000, it progressed more than 15% per year. At the end of 2.5 years, half of them had had a heart attack. If the calcium score was over 1,000 and the calcium score was stable, progressed less than 15%, they had the same number of heart attacks as every other level of calcium. And so it's not the old calcified plaque that ruptures and causes your heart attack. It's the new plaque that we're laying down right now that ruptures and causes the heart attack. And so in my practice, I have a relatively smaller practice right now. I only have about 750 patients in my practice. 500 of them are over the age of 65. Most of them are intermediate to high risk based on their risk factors, based on previous coronary events, based on their calcium score. I treat not to your cholesterol goals or to your blood pressure goals. I treat to calcium goals. I treat to make their calcium scores stable. By doing that, the last heart attack I saw was November 9th, 2009. I've not seen a heart attack in over 2 years. The last coronary death I saw was 7.5 years ago. 8 years ago, before I started doing this technology, I lost 4 patients, 4 friends within an 18-month period to sudden unexpected coronary death on my watch, with them doing everything I was asking them to do. It was at that point in time that I realized this is not working for me. It's about the same time I found out about calcium technology. And I'm gonna see another coronary event someday, see another coronary death someday. But to say I've not seen a coronary death in 8 years and not admitted someone to the hospital with a heart attack in over 2 years, pretty remarkable statement. So can we make heart disease go away? Yeah, we can. Do we do it by putting everybody on statins? No. That'll reduce heart attacks by 20%. It'll still leave coronary disease the leading cause of death in this country. We can do it by identifying who's at risk, who's not at risk, and whose treatment's working and whose treatment's not working, and crank up the treatment to make it work. And that's my story. Yes, sir.
Are you familiar with Dr. S.'s team's work on preventing worsening heart disease? And what's your thoughts on that?
XD, you said?
I think it's S.'s team. Clinton actually attributes a lot of success with that research.
The short answer is no, but is this coming off of the ABC special that Sanjay Gupta did?
He may have been on
Yeah.
CNN recently.
Yeah, there's an expert who's very much into a vegan diet, very basic diet, and saying you can stop most coronary disease by doing that, and I believe that's probably true. I think there are a lot of ways to stop coronary disease. The problem is, if you're on a Pritikin diet or an Ornish diet, you'll probably stop coronary disease, but not very many people can be on a Pritikin or Ornish diet. So basically, with the coronary calcium score, I'm able to titrate what needs to be done to the person within their ability to do it. And I have diabetics who have major amounts of plaque in their vessels, whose plaque is stable, and they're doing fine. I have one guy who's got a calcium score of 9,400. This guy climbs mountains, he treks across Alaska because his calcium score is stable. When he came in as a patient, he was having some chest discomfort. We got him on the right preventive treatment, and his chest discomfort went away. His plaque burden went away.
So how do people reduce their calcium?
Simple. Hey, that's easy. First off, alluded to it earlier, vitamin D is actually a critical part of the calcium metabolism. If your vitamin D level is less than 20, you have 2.5 times the risk of a heart attack compared to a vitamin D level greater than 50. And association does not equal causation. With vitamin D, it probably is causation. And so one thing is to try to get people's vitamin D levels up above, at least above 45, between 45 and 70. Number 2, lower the LDL cholesterol. How do you lower the LDL cholesterol? The standard way is to use a statin. It turns out diets high in vegetables lowers the LDL cholesterol better than diets low in fat. And so I push vegetables. I suggest patients eat 8 servings of vegetables per day. So we correct their vitamin D, vegetables, fish oil, omega-3 fatty acid. Japan has 1/3 the heart attacks of the United States. Japanese Americans have 30% more heart attacks than Caucasian Americans. So it's not a function of being genetically Japanese, it's something that happens in Japan that doesn't happen here. What's different in Japan? The average daily consumption of omega-3 in this country is 150 milligrams, in Japan 1,500 milligrams. Japan also eats more seaweed. There's probably vitamin K in seaweeds that's beneficial from a cardiovascular perspective. In Japan, they eat less wheat starch. There's theories about the gluten in wheat starch being pro-inflammatory and being contributing to coronary disease. But when you look at those three factors, the omega-3 fatty acids really stand up. They did a study in Japan, patients already taking a lot of omega-3s, randomized them to taking no additional omega-3s versus taking an additional 1,700 omega-3s on top of a trivially low dose of statins, a homeopathic dose of statins. The group who was on the additional 1,700 milligrams of omega-3 had an incremental 25% reduction in heart attacks. That's a better reduction than we see from statins. And so this was adding omega-3 on top of diets high in omega-3. So I use a lot of fish oil-derived omega-3s.
Sorry, what diet did you say? Was it Pritikin
Or Ornish diet. Yeah, those are examples of sort of extreme diets that probably work, that no one can stay on. I mean, Binks Selby's set point diet probably works. Nobody can actually stay on it. And so my point is that normal people doing normal things can stop their heart attacks from happening. Sleep apnea. Sleep apnea is a very common underdiagnosed entity in this country. Sleep apnea is associated with a significant increased risk of coronary events. It's an easy thing to treat. It's not a hard thing to treat. I have sleep apnea. I treat it with this little device that my dentist made for me, put it in my mouth at night. My wife likes it because I don't snore anymore, and I like it because I wake up refreshed in the morning. So treating sleep apnea, treating preclinical diabetes, getting rid of smoking, exercise. In Boulder, when you say exercise, you think triathlete. It turns out that a 20-minute walk 4 times a week has 80% of the benefit that any level of exercise will do. So not all of my patients can be triathletes. One could argue that maybe I couldn't even be a triathlete. But no one can't walk 20 minutes. That's pretty easy. So you put that all together and we come up with something that works. The plaque burden stabilized. Yes, I use statins. I don't use high-dose statins, but for patients who can't stabilize their plaque, we'll add a statin. Something called bile salt sequestrant. Bile salts are things excreted by your liver to help digest fats in your gut. Bile salts are made out of cholesterol. Normally, we reabsorb bile salts in the terminal ileum and reuse them. Bile salt sequestrant is little resins that bind the bile salts to get excreted in the stool. The liver has to make new bile from cholesterol, and it lowers your cholesterol. So there are a number of ways. Servings of viscous fruits and vegetables. The viscous fiber within fruits and vegetables is thought to work as a bile salt sequestrant. So fruits and vegetables, not only do you get the benefit from the antioxidants, but you get the benefit of the viscous fiber lowering your LDL cholesterol.
What's the procedure for the testing?
The testing, I may have a picture of it, let me just see. Yeah, here we go. This is what the machine looks like. It looks like a CAT scanner. The difference is there's no moving parts. Instead of having the thing rotate around the patient, which takes time, an electron beam hits a tungsten target, you get a little wedge of radiation from 2 different directions, and we get a 3-dimensional image in 1/10 of a second. And so you hold your breath, we do 3-millimeter slices through the heart, and then we measure the calcium in the heart. I talked about the EBTs, what I do. 64 slice scanners is what is the current rage in cardiology. 64 slice scanners can do CT angiograms pretty well. The problem with 64 slice scanners is because it takes a 1/4 of a second to a 1/3 of a second to take the picture the heart moves, the calcium scores are not very accurate and are not reproducible. The scan acquisition on EBT is a 1/10 of a second. The fastest 64 slice scanner is a 1/4 of a second. This is the same picture. This is what a calcium score looks like. This is the heart. This is the middle portion of the right coronary artery. This is an EBT scanner. This is the same patient, same slice, 64 slice scanner. If you're trying to get an accurate metric of how much plaque is there, you'll do a lot better with the EBT than with the 64 slice scanner. So according to the AHA scientific statement, the 64 slice scanners have up to 43% scan-to-scan variability. Variability of the EBT is 5 to 15. Since plaque stability is measured by plus or minus 15%, using a scanner that has a 43% fudge factor is not going to work for you. Yes, ma'am.
So maybe one more question because we're running close on time.
What's the
Excellent.
cost?
Well, actually, it depends on where you get it. We're right now still doing a special for $195. We usually charge $395 for it. I'm trying to see if I can get enough people in that I can come close to breaking even at $195. That would be my choice, because I'd rather do more good for more people than fewer people.
Is $195 have the scan?
Yeah. Yeah. How often can you get to ride on a $2 million piece of equipment for $195, huh? So that's why I need you guys to do virtual colonoscopy so I can afford to keep doing this stuff.
All right, let's give them a big round of applause.